Thank you. All right, well, let's go ahead and get started. Welcome, everybody, to our Payment Pathways for Food as Medicine and Non-Medical Drivers of Health in Texas webinar. I'm Shrila Sharma. I'm a professor of epidemiology and director of Center for Health Equity at UT Health Houston School of Public Health. I'm based out of Houston. And I'm joined here by two wonderful colleagues. Erica Hansen, she's a clinical instructor and attorney at the Center for Health Law and Policy Innovation of Harvard Law School, where her work focuses on addressing the social determinants of health and health equity. And through this work, she advises community-based organizations, state and federal agencies, and coalitions regarding the legal pathways and policy implementation strategies to integrate payment and delivery of health-related social needs services into our healthcare system, such as food and housing support for those experiencing chronic illness, high-risk pregnancy, and others in need. I'm also joined by Lisa Kirsch. She is the Senior Policy Director at Dell Medical School at the University of Texas at Austin. She conducts health policy research and analysis to support innovations in healthcare delivery and payment. Prior to joining DelMed in 2016, Lisa worked for over 13 years at Texas Health and Human Services Commission, or HHSC as we know it, on Medicaid and Children's Health Insurance Program policy issues. Most recently, she oversaw the policy department and the development and implementation of over $10 billion delivery, as we know it as DSRIP, Delivery System Reform Incentive Payment Program under the Texas's 1115 Healthcare Transformation Waiver. So thank you again, Lisa and Erica, for joining us. We are excited to go ahead and get started. But before we get started, if you can go to the next slide, please. The webinar is hosted by the Center for Health Equity. Our vision is we see a world populated by healthy people across flourishing communities. And you can learn more about the center. We have the QR code here or the website, but our primary focus is to build sustainable solutions to promote health across diverse communities. Next slide, please. So I'm going to just take a couple of minutes to really frame the webinar for today. On both a state and a national level, we have seen increased momentum to address non-medical drivers of health, or the conditions in the place where people live, learn, work, and play, which account for as much as 50% of health outcomes. Now, in particular, in Texas and other states, we are prioritizing policies and programs that address food insecurity, diet-related chronic conditions, such as diabetes and heart disease, which we know are the leading cause of death in the United States and cost the economy about $1 trillion annually. Nationwide, policymakers and healthcare leaders are looking to tackle these problems by taking advantage of creative and flexible opportunities to incorporate food as medicine interventions and other non-medical drivers of health services into healthcare payment and delivery systems. We hope you leave today's introductory learning session with new ideas on how Texas can build upon the work that's already happening in this state to address priority medical, social, and population needs through strategies that have been successfully employed throughout the country. We will only have a brief time at the end of today's presentation for questions and discussion. However, we invite you to join the Texas Consortium for Non-Medical Drivers of Health policy crowdsourcing workshop tomorrow at 11 a.m. and also on June 11th at 3 p.m. to discuss these topics to help the consortium generate specific, actionable policy proposals for supporting the integration of non-medical services into the healthcare delivery system. And we'll put a link in the chat in regards to the crowdsourcing webinar for everybody to register and join. Next slide, please. So the medical, social, and population health needs of Texans are unique and varied. Stakeholders have identified some priority areas of focus, however, including maternal and infant health, mental health, substance use disorder, and increasing enrollment in and coordination with existing social safety net programs such as SNAP and WIC. Now, in 2023, a study showed that maternal mortality rates in Texas more than doubled between 1999 and 2019, increasing from around 10 deaths per 100,000 live births in 1999 to 22 deaths per 100,000 live births in 2019. And according to the Texas Maternal Mortality and Morbidity Review Committee and Department of State Health Services, 90% of our pregnancy-related deaths were preventable. The committee found that a multitude of non-medical drivers of health, system-level, and community-level factors contributed to these deaths, with obesity the second leading factor behind violence, contributing to 1 out of 5 deaths. Finally, far too many babies are being birthed before 37 weeks of gestation or do not survive past birth. Mental health has also been identified as a priority area. Nationally, Texas has relatively low prevalence of mental health and substance use issues. However, we rank last in access to mental health resources in a survey, considering access to insurance, access to treatment, quality and cost of insurance, access to special education, and workforce availability being some of the issues related to access of these resources. And finally, Texans have access to long-standing and proven social safety net programs. For example, WIC is widely recognized as one of the most effective nutrition programs in the United States. WIC participation is associated with decreased preeclampsia, increased length of gestation and birth weight, decreased preterm delivery and NICU stays, decreased infant mortality, and reduced racial disparities in maternal and birth outcomes. Additionally, these programs help local communities. For example, every federally funded SNAP dollar generates $1.79 in economic activity supporting farmers, food producers, food retailers, and other businesses and creating jobs. However, the challenge we have is that we still have large gaps between those eligible for the programs and those actually enrolled. Now, while there's not one policy that addresses all of these and other priority needs in Texas, emerging and promising opportunities for food as medicine and non-medical drivers of health are taking off all around the country. So to give us an introduction to some of these pathways, I'll pass it to Erica Hansen. Erica?
Thank you so much, Srila, and thank you all for joining us today. I'm really excited to have you with us. So as Srila mentioned, we're seeing accelerating federal support for and state and program adoption of policies that support the incorporation of food as medicine and other services that support the non-medical drivers of health, so things like housing supports, into patient care and insurance coverage, particularly since the Centers for Medicare and Medicaid Services, or CMS, released guidance detailing these opportunities for addressing the social determinants of health in Medicaid and CHIP in January of 2021. A recent peer-reviewed analysis of state adoption of just one of these pathways, called Medicaid 1115 demonstrations, which we'll get into a little bit later, found that this rapidly growing interest and evolving policy in this area owes to a few factors. First, the onset of the COVID-19 pandemic in March 2020. Several states' documents explicitly discuss the pandemic's impact on health outcomes, racial and socioeconomic health disparities, healthcare delivery, and Medicaid enrollment, which went up during this period. The pandemic also called attention to the high rates of diet-related chronic diseases, and COVID-19 response packages included funding and policies that supported food as medicine programs and other non-medical drivers of health. Second, there was really an accumulating number of peer-reviewed studies showing the health outcome, cost, and utilization benefits of specific food as medicine interventions, like medically tailored meals and produce prescriptions. And third, a final major driver that this study found was increased attention at the federal level to the social determinants of health, poor nutrition, and health disparities, such as the second ever White House Conference on Hunger, Nutrition, and Health in September of 2022. So I wanted to have a quick note on terminology. There's many programs and interventions to address food insecurity and nutrition, and different people can mean different things by the term food is medicine. So when I'm using that term in this presentation, I'm going to use the definition from the Aspen Institute's Food is Medicine Research Action Plan, meaning that I'm referring to interventions that are tailored by medical providers to respond to the connection between food and health. So these interventions are helping to prevent and treat diet-related conditions. And these are programs that build upon existing nutrition security programs that Srila just mentioned, like SNAP and WIC, and population healthy level food policies. And these interventions provide access to nutritious food as part of a patient's treatment plan. And these interventions typically encompass medically tailored meals, medically tailored groceries, and produce prescriptions. And I want to focus on these interventions because they do not currently have a sustainable federal funding stream, unlike SNAP and WIC. But they have a lot of promise to address those priority needs that Srila was just discussing. So while these food is medicine and other non-medical drivers of health interventions can have a really powerful impact on health outcomes and costs, which we'll dig into a little bit later, there's no baseline coverage of these services in our health insurance programs, or as I just discussed, really any federal funding stream, sustainable federal funding stream. So historically, as many of you in this room know, funding to support these services has been provided on a limited or pilot basis through private or grant funding, which can really limit the availability and sustainability of these services and programs. However, as noted, we are seeing accelerating development and adoption of legal flexibilities that allow for the coverage of food as medicine and other non-medical driver services in healthcare. So this slide, I know it's a little bit busy, but it summarizes sustainable healthcare payment and delivery pathways available for these services. And in the next few slides, we are going to go over some of the pathways in more detail that have been identified by some Texas stakeholders as pathways of interest, and also pathways that have been utilized successfully in other states across the country. So generally, with CMS approval, so with federal approval, states can implement experimental pilot or demonstration projects in their Medicaid programs through what are called 1115 demonstration waivers. So for example, states can cover services such as food as medicine services that are not normally allowed to be covered in Medicaid under federal law. These demonstrations can do a lot of things, not only non-medical drivers of health demonstrations. So Texas currently has an 1115 demonstration, right, that does a lot of Medicaid experimentation. And states throughout the country are doing various experiments under 1115 demonstrations. And these, what are called health-related social needs demonstrations, are only one of those flexibilities that this pathways allows. So this chart summarizes some of the key takeaways about this pathway. So importantly, in exchange for this flexibility that Medicaid 1115 demonstrations allow, there are some requirements that states have to follow. So as I mentioned, CMS has to approve these state proposals for demonstrations. They have to promote the objectives of the Medicaid program to provide insurance coverage for low-income individuals and families. These are not permanent changes to the Medicaid program. Initially, they're typically approved for 5 years, and they can be renewed for 3 to 5 year periods. They do have to be budget neutral to the federal government. That means the cost to the federal government with the waiver must be the same as they would have been without the waiver. Although CMS has released guidelines for 1115 demonstrations that make these budget neutrality guidelines more flexible for health-related social needs services, such as food as medicine services and housing supports, and infrastructure that makes these requirements more flexible. There are spending caps on health-related social needs costs to keep the fiscal integrity of the system, given that flexibility and budget neutrality requirements. So costs are limited to 3% of annual Medicaid spending for the state. But there are infrastructure funds available, which is very unique in this space. And it is only available under 1115 demonstrations. And these funds allow for the state, for Medicaid managed care plans or MCOs, for community-based organizations that are delivering these services, and other stakeholders to invest in things like technology, development of business practices, workforce development, so hiring people to deliver services, and outreach, education, and stakeholder convening. There's also a cap, a spending cap on these services. The services allowed, CMS has released guidance on this. There's 5 nutrition services, up to 3 meals a day, a full nutritional regimen, and 10 housing services. Other services as approved by CMS. We're going to dig into nutrition services coverage trends as well as target population trends a little bit later. This is the broadest of the pathways that we're going to discuss, in that patients' reach can be statewide as long as the services are medically appropriate under a state-determined clinical and social risk factors. The state adoption of this has been very broad. So currently 23 states have approved or pending 1115 demonstration waivers that include some type of nutrition service. So that could be food insecurity screening, nutrition education. But 8 of these approved demonstrations and 6 pending include the direct provision of food. So things like medically tailored meals and produce prescriptions. An additional 6 states have legislation pending that would further an 1115 demonstration, including in Alaska and Minnesota. This legislation has passed. This would direct the Medicaid agency to submit an 1115 proposal that would cover health-related social needs services. Those bills are awaiting governor's signature in those states. Another very popular coverage pathway in Medicaid for food is medicine and other non-medical driver of health services is called in lieu of services. Again, there are several requirements that are placed on this pathway by CMS or the federal government. This requires state approval. So states can approve Medicaid managed care plans or MCOs to cover otherwise non-covered services, so things like food as medicine services, as a medically appropriate, cost-effective substitute for services that are covered under the state plan. So an example of this would be like medically tailored meals covered in lieu of hospitalizations and emergency department visits or nursing facility care. And the theory behind this is that medically tailored meals, so like home delivered meals that are tailored to the patient's condition, can actually prevent the need of, say, an emergency department visit or nursing facility care in the future. In order for this to be approved, the state has to show to CMS that the cost percentage, otherwise known as the total capitation payments that the state attributes to these services, the in lieu of services, divided by the total cost of the specific managed care program. So like if Texas has a separate managed care program for people who get long-term services and supports. That cost percentage would be calculated separately from the other managed care program for other individuals. That can't exceed 5%. Otherwise, CMS will say that the state cannot do that in lieu of services. So all in lieu of services need to have a cost percentage that are less than 5%. And importantly, in lieu of services cannot cover room and board, meaning that nutrition services cannot cover 3 meals a day or a full nutritional regimen. So unlike 1115 demonstrations, which can cover 3 meals a day, in lieu of services are 2 meals a day or less, or not a full nutritional regimen if you're doing something like produce prescriptions. There's some other requirements like the costs of in lieu of services have to be included in the managed care's capitation rate in the managed care contract. There's various enrollee rights that have to be protected. There's monitoring activities that the state and the managed care organizations have to do, and various other requirements. The services allowed, there's 5 nutrition services with that room and board restriction. There's 8 housing services with that room and board restriction, and then other state approved services under the in lieu of services requirements. The patients reached are narrower than under an 1115 demonstration. So this is for Medicaid managed care enrollees only. Fee for service or straight Medicaid enrollees cannot access in lieu of services. These are optional for the Medicaid managed care organization or plans to provide, right? So the state can approve these services, and then it is up to the plans whether or not they want to offer it to their enrollees. Very similar to 1115 demonstration, the state develops and CMS approves clinically oriented definitions for the target populations, and we'll talk about trends later. In terms of state adoption, 6 states have approved various nutrition services. So things like nutrition, education, diabetes programs, and the direct provision of food. And then 2 states are currently contemplating approval or implementing approval. Another very promising strategy that various states have implemented and that Texas may be interested in implementing is Medicaid contracting. So this is the requiring or incentivizing payers or providers to offer services through the contracting process. And a very popular way of doing this is through what's called value-based payment. And I know a lot of you are very familiar with this, but these are just payment models that reward performance. And there's various ways to do this. And so these are just a couple of examples on this slide. So there's ways to encourage provider use of services that address the non-medical drivers, right? So this could be things like encouraging use of services to address food insecurity or housing insecurity, right? And then rewarding those provision of services through payment. You can encourage the implementation of comprehensive care coordination, right? So contracting requirements to include screening for non-medical drivers of health, right? Or the social determinants of health, requiring partnership with community-based organizations and or use of referral systems. And I will show you later on what Texas currently has in your Medicaid managed care contract that can possibly be built upon in this area. There's creating performance incentives or withhold payments tied to quality benchmarks, right? Like bringing down the share of enrollees with a certain A1C level or just with diabetes generally, right? In order to receive payments would be an example of a withhold payment. Adjusting capitation rates to account for social risk factors or risk adjustment, right? So Minnesota is an example of a state who has done this well. Or instituting community reinvestment requirements, right? That plans are required to invest a certain amount in the communities in which they operate. And then finally, it's been identified, right, that there is a large share of uninsured populations in the state and private insurance, right, really outside of Medicaid. And to get to these folks, state pilots, private insurance, other avenues of funding are really important. And pilot programs also provide critical resources for seeding, evaluating, and expanding access to food as medicine interventions and other non-medical drivers of health. Unfortunately, though, they're typically not long-term or statewide solutions. And so as a result, many states are fostering programs born out of these pilots through the sustainable funding options we just discussed in order to maintain and expand successful programs after their initial grant periods. But these are really important and kind of blend and braid, right, to cover sometimes those individuals that can't be covered by Medicaid or maybe private insurance. So I've linked here to several pilots that other states have done. And in California, North Carolina, these pilots were really integral to leading to the 1115 demonstrations in those states. You can see there's a variety of different ways to structure these based on these examples. Also, there's many private insurers that are covering and offering food as medicine and employer and individual plans, but unfortunately, these are just notoriously difficult to track and consolidate because the information is spread across individual insurer websites and plan documents, but I've included several examples here. I also wanted to highlight that nutritional counseling and food and beverages purchased for health reasons can be paid for or reimbursed by health savings accounts if they meet IRS requirements. I'm unaware of this happening to date, but it's kind of a really interesting area to explore. I love this slide. This is more of a resource for you all, and we'll share out the materials from this presentation afterwards. But kind of looking through a comparison of these pathways, this is a really nice potential pro and potential con when looking through why a state might go with one pathway versus another. There's also states that have kind of mashed them all together or used multiple pathways at one time. California, New York have both used 1115 demonstrations and in lieu of services, for example, and value-based payment is really big in New York as well. So very quickly, I just want to address some of the trends we're seeing nationwide in food as medicine. So the target populations, interventions covered, program evaluation, and then some kind of wider benefits that are really driving this momentum that we're seeing of payment and delivery of these services through the healthcare sector. So an evaluation of 1115 demonstrations across the country, we're really seeing that the primary target populations of this policy pathway are individuals with chronic diet-sensitive conditions. So these are things like diabetes, HIV, cancer, and then individuals with mental health or substance use disorders, and then individuals who are pregnant or postpartum, and that's actually the most popular population that are targeted. We're seeing very similar populations targeted in lieu of services, although those programs tend to be a little bit more narrow. So like it's only individuals with diabetes, say, instead of kind of a larger swath of chronic diet sensitive conditions. As for the interventions that are covered, this has really been dictated by guidance that was released on November 16th, 2023. It was CMS released this informational bulletin detailing the coverage pathways for services and supports to address health-related social needs in Medicaid and CHIP. And the bulletin included an attached table listing the health-related social needs services and supports CMS considers allowable under 4 authorities, which was in lieu of services or IOLS, home and community-based services or HCBS, or Section 1915 waivers, Section 1115 demonstrations, and finally Children's Health Insurance Program or CHIP health services initiatives. And the guidance also details kind of applicable limitations on service coverage. And this guidance really built on years of federal guidance, including a CMS letter that I mentioned earlier from 2021. And so this guidance analyzed 5 nutrition supports that are listed here on the screen: case management, nutrition counseling, home delivered meals or pantry stocking, nutrition prescriptions, and grocery provisions. And states have the flexibility to cover all or some of these interventions within the pathways, and states don't even have to follow this framework. They can propose something to CMS, negotiate with CMS, and see where they get. However, kind of sticking to the framework presented here will likely speed negotiation and approval with CMS. So this has kind of been a helpful way of thinking through what services will be approved in the nutrition space and also the housing space, which was also included in this November guidance. I also wanted to highlight in evaluation, we have a brand new evaluation report out of North Carolina of their 1115 demonstration. Some background on their demonstration: it was developed as a part of the state's transition to Medicaid managed care, which was legislated in 2015. Their 1115 demonstration was approved under President Trump in 2018, and it provides 29 evidence-based interventions related to housing, food, transportation, and interpersonal safety and toxic stress to high needs Medicaid enrollees in 3 regions. And the Medicaid agency anticipated increased screenings for social risk factors, more connections to social services, and therefore improved healthcare outcomes and lower healthcare costs. So this interim evaluation report was released in April 2024. All 1115 demonstrations require an independent evaluation, and this is the broadest evaluation of a health-related social needs 1115 demonstration that we have to date. And it measures from services launch through November 30th, 2024. So roughly the first 18 months of the pilots. You can see that each service launch was a little bit staggered from this graph that I have here on the slide. So not all services were running for the full 18 months. So the key takeaways you can see here is that this demonstration was highly effective. It reduced enrollees' total number of social needs. It had statistically significant findings that it decreased emergency department utilization by 6 emergency department visits, reduced inpatient hospitalizations for non-pregnant adults by 2 admissions per month. Service spending, which was medical care and the pilot services, was on average $85 less per participant per month. That's outstanding. And they found that longer participation in the pilot was associated with greater reductions in spending. So the example that they used is 12 months of participation in the pilot, so like 12 months of receiving food services was associated with greater reductions in spending than 6 months of participation. And then finally, I wanted to highlight, that research shows food as medicine improves health outcomes, that it can reduce healthcare utilization, as we just saw, and can also support food system and the agriculture sector, as well as local economies. And states are really building in policies and payment mechanisms to further these state priorities. And at the very bottom here, you can see that Texas has started on this journey. So Texas's Medicaid managed care scope of work currently requires MCOs or Medicaid managed care organizations to use an evidence-based screening tool to assess enrollees' health-related social needs, organize referrals to community organizations for social services, and provide healthcare staff with information about relevant resources in the community. So Texas is well on the way in this realm, and I'm going to pass it off to Lisa to talk about what else is going on in Texas, because it's quite a bit.
Thank you, Erica. And I'm just going to take a couple minutes, and I'm speaking to the choir here, I know that, on where we are in Texas and also what some potential next steps might be. And many of you are doing this work, so you have heard some of this before. But I just wanted to highlight a lot of the work in Texas has happened at the local and regional level, and that's sort of the nature of what Texas is in terms of our size and diversity. Also coming out of DSRIP, right? We've kind of intentionally allowed regions to innovate. But now I think looking forward, it is interesting to step back and say, okay, from a Texas standpoint, how can we drive change going forward? So just at a high level, Last year, HHSC released its non-medical drivers of health action plan with 3 priority areas based on the population's needs. Food being kind of the front of the timeline there, also housing and transportation. So Medicaid and CHIP clearly signaling that they see food as an area that we can be working on to improve health for Medicaid and CHIP recipients. A big excitement for all of us last session in 2023, the legislature passed House Bill 1575, which is now law. Really, to me, this is foundational. It does a couple things. It standardized non-medical drivers of health screening for pregnant women in Medicaid managed care, and also added as providers for pregnant women in Medicaid, community health workers and doulas. And this is for targeted case management. However, I would just say that both of these things, I think, give us opportunities to build. So the non-medical drivers of health screening, and there's been a lot of discussion around this, but how do we do this best? It is a health plan responsibility, but how do they partner with providers, with community-based organizations? What's the most effective way to screen women and get them services? So I think a lot of really good conversation there. And around community health workers and doulas, once they are added as provider types, that reduces the barrier for maybe using them for other things that might be beneficial to recipients of Medicaid. We do know that community health workers, HHSC has been evaluating whether it would be cost effective to add them for diabetes and asthma education as a Medicaid benefit. So again, having them as a provider type just kind of reduces the barrier to entry if we find that they could be helpful in other ways for our recipients. There's been for a number of years a learning collaborative sponsored by foundations, including the Episcopal Health Foundation and the Michael and Susan Dell Foundation, in partnership with health plan associations and Health and Human Services, where there's been a lot of sharing around what is going on in Medicaid managed care in this space. So that work continues. And recently, HHSC revised its alternative payment model framework, which has been in place for a number of years and is encouraging its health plans to have more payments to providers be in value-based arrangements. So that there have been percentage targets. For example, 50% of all payments should be in some type of a value-based arrangement. A couple of years ago, an advisory committee that I'm a part of said to HHSC, we keep the targets, but we also think there should be some more qualitative aspects to the alternative payment model framework. And they are now implementing that beginning this year. So things like health plans getting credit for arrangements that address non-medical drivers of health or priority areas like maternity care or integrated behavioral health care. So that's kind of hot off the press, but I think we'll learn a lot from that new framework. Also, and you've heard this already, the Texas Non-Medical Drivers of Health Consortium, which was founded by Elena Marks and is now directed by Charles Mathias. That's those crowdsourcing events that are happening tomorrow and next week that I'm going to talk about more. They are another resource that is looking to share information in this space. And there's a screenshot here of their website where they are asking folks to send them information about what they have going on in this space in Texas. There is a lot of work going on, including around food. So would encourage you to check out that index if you haven't already. Many of you are doing pilot work in this space, and too many to mention. And a lot of those are also being pretty rigorously evaluated on food is medicine interventions for targeted populations. Just to name a couple that I know about, here in Austin, Factor Health at Del Med is doing the Meals for Me Managing Diabetes at Home program. We're also doing some work with Driscoll Health Plan in South Texas, which has a program called Nurture, nutritional support for high-risk pregnant women. Also in Houston, Shrila and team, I mean, there's a lot going on in Houston as well. Brighter Bites Pediatric Produce RX, Harris Health Food Pharmacy, and so many others. So I know that those are just a snapshot, but these are being evaluated on, is this helping pregnant women or diabetics or young children? And if you're thinking about different kinds of interventions, what is the most effective type of an intervention, right, for this particular target population? I wanted to mention too, Rider 89 from last legislative session, which HHSC is working to implement now, which appropriated $6 million for nutrition incentive programs Something like the SNAP Double Up Food Bucks, where if you spend your SNAP money on fresh produce, you kind of double the value of those funds, right? So that's an explicit nod to food as medicine from the Texas legislature. And it's really building on other SNAP legislation that has passed the last couple of years, including reducing barriers to eligibility for seniors and folks with disabilities in SNAP. And last session, increasing the vehicle allowance. So I know those are foundational programs that Food as Medicine builds on. But I think, again, the fact that our leadership is making improvements in that program to address food insecurity gives us a better foundation to build some of these programs off of. And last but not least, I have to mention data sharing. And I mentioned this with regards to House Bill 1575 as well. But how do we share information between health plans and providers and food banks and other community-based organizations about screenings, about folks' needs, so that we can best together help get those needs addressed? So there's a lot of local and regional work going on around this, building off of the Accountable Health Communities work that CMMI supported, including in Houston, Dallas, San Antonio, and Austin. So I don't want to lose sight of that as work that's going on that's important. And next slide, please. So where do we go next? I have a lot here. I mentioned those crowdsourcing workshops that are happening that we encourage you to sign up for to talk about all this. I think the information that Erica provided is just extremely valuable and informative as we think about what might be the best next steps for Texas. So it's been helpful to me. I hope it's been helpful to you. The committee, the Value-Based Payment Committee, that I participate in, has a lot of recommendations coming out around all of this in our report this year. And those recommendations have already been voted on. So happy to share those if folks are interested. But really 3 things. We're working to expand the evidence base in support of food as medicine programs. That's going on all around Texas. What works and for whom does it work, right? So when we're talking Texas Medicaid, for pregnant women, for children, for diabetics, for folks who are at risk of end-stage renal disease, kind of what works best for whom. That's important. And then there's increasing our investment in these programs. And last week, I listened to a webinar that my colleague Bella Kirshner from Central Texas Food Bank asked the question, how do we get beyond pilot and grant funding, right? And I think that's why we're here and why these crowdsourcing workshops are happening. There's so much going on in Texas, including with health plans, including with a lot of partners. But how do we get to that next stage? There is infrastructure and technical assistance support needed. We know that, and we've seen it in states like North Carolina and California that have attempted this at a greater scale. So, you can encourage the health plans to do things. You can grant fund things. But without sort of some broader state direction, it's going to be hard to get beyond where we are now. And that gets to the crux of all of this. How do we sustain effective food as medicine programs? And what's the best way to pay for them? And I'm not going to answer that today, but I will say Texas does have, and I've talked about it, right? There's a lot going on in this space. We are encouraging our health plans to do this work through value-based care. But without a way to pay for these services in a way that sustains them, the health plans are going to do what they're financially incentivized to do. And so they're doing work in this space, and I'm going to say around the edges, but within their existing authorities. And I think this is where we have an opportunity now to say, okay, is it pregnant women? Is it chronic disease management? Is it in lieu of services or an 1115 waiver, or maybe more value-based care directive? But what's the next step that Texas can take to move this forward? And I do think some state level guidance on that beyond what's happening already, which is a lot, will be extremely valuable. So with that, I'm going to turn it back to whoever is moderating. So hopefully we can have a little bit of discussion.
Naomi and Katie, are y'all moderating the Q&A?
Yes, so we've had a couple questions in here, and Katie has done a fabulous job of answering some of them. We do have a question here from Lindsay. So it says, why is the focus of this work centered around MCOs doing the work and not providers? And a side note, we've been doing this work for decades as providers.
Erica or Lisa, one of y'all want to take that?
And I would say that, and it certainly, I think that the health plans are one of the partners, right? And a vehicle that we have to do this work is through Medicaid managed care and the authorities that Erica discussed through 1115 or through in lieu of services or value-based contracting. Medicaid is the vehicle that we have, and Texas is a Medicaid managed care state. So they're a partner, but I think we really want to be thoughtful about what role they should play, what role the community-based organization should play, and what role primary care providers and other providers should play, right? Because I agree, there is so much good work going on, and it's how do you do it best with all the players? It's just the financing vehicle that we've been discussing, right, as a way to get some federal support to do this work.
Ditto. I just think that's where a lot of the movement has been, but definitely in like the value-based payment world, which Lisa has been talking a lot about. Like there's some space there for like direct provider payment, but there just hasn't been as much movement there. But there's definitely some things to explore.
So that's all the questions that we have in the chat for now. I know, oh, wait. Sam says, how will the significant MCO service area changes made in the last round of plan procurement impact the momentum of these efforts?
So that is a great question. And I think this is still shaking out, right? As we have some potential challenges to the awards that were made. And we're always mindful of what's going on with the managed care reprocurement as we think about the timing of all of this. But no matter who, at the end of the day, are the plans that we have for Star Plus or for Star or for CHIP in each region, a year, a couple of years from now, they're going to be looking to partner, right? They're going to be looking to meet the state's contract requirements. And so there's a little bit of shaking out that still needs to happen. I would just ask folks to hold tight on that. And once we know more, then you'll have a better sense about, which health plans you might be partnering with in your region.
I also think, I mean, you all like know, of course, the ground game much better, but often in these moments where things are kind of shaking up with health plans or healthcare generally, it's an opportunity. Like it can be an opportunity to have new partners and to introduce new opportunities for, cost savings and population health improvement, right? And if you have a new plan in your area, they may be looking to build goodwill with new members and new providers, and things like non-medical drivers of health are a great way to do that, right? They often build a lot of member retention, as well as doing things like driving down long-term costs. So that can be a really nice selling point and a good way for plans and community members to kind of come together for population health, especially when there's kind of like new players in the area.
I just wanted to direct a question to Lisa from a Texas standpoint. It's a question from Kenyanda. Can Texas add food as medicine to current 1115 waiver or add a new one? And I know, and Katie has done a nice job of framing it broadly, but from a Texas standpoint, do you have any specific thoughts?
So I would say either of those would be an option. I do think that because Texas has a large existing 1115 waiver that the federal government has authorized for a pretty long runway here, I think Texas would be very thoughtful or cautious about amendments to that. But I do think there's opportunities to amend it to incorporate food as medicine. Yes, either one, right? If 1115 seems like the best vehicle that folks think that we should be pursuing. All of this takes resources, right? And I'm very aware of that. Whether you do in lieu of services or value-based contracting or 1115, there's a lift. It's like North Carolina's waiver did not start out without a very heavy lift. So it's thinking through, I think, where we strategically have the best opportunities.
Well, thank you so much. We are almost at the top of the hour. I just want to say a huge thank you to Erica and Lisa for joining us, and also Katie and Naomi for supporting the webinar. I want to invite everybody to the workshops hosted by the Texas Consortium for Non-Medical Drivers of Health. And we also will have a follow-up second webinar that's focused more on community-based organization and healthcare partnerships and non-medical drivers of health. That webinar will be hosted probably early fall is kind of what we're thinking. So stay tuned for that. But again, thank you everybody for joining us. This webinar is recorded, and we will send out a recording through the registrants and also post it on our Center for Health Equity website. So thank you, and have a great rest of your week, and stay dry. We are wet here in Houston right now. Well, thank you all. Bye.